going to discuss about the examination of thyroid gland or about the examination of any lump in the neck. The doctor will examine the patient. Would you please come and examine this patient? So doctor is going to wash his hands. He is washing his hands.
Good afternoon, sir.
He is introducing himself. He is greeting the patient as well as introducing himself. Yes, please carry on.
Good afternoon, sir. My name is Prof. I'm a final year medical student from Manipal Medical College. I'm today here to examine your thyroid gland, so I need your consent for that. Yes.
So he has taken the consent of the patient, but he will also explain the procedure to the patient. He will explain how he will be examined. The doctor will maintain the privacy. There should be proper exposure of the patient, and once the consent is taken, he will proceed further. Yes.
First up, I would like to start with the inspection of your neck. Okay.
So he is doing inspection of the neck. He has brought his eyes in line with the thyroid gland. So it is, and he is seeing it from the front so that he can see it nicely. He can observe.
On inspection, there is a diffuse swelling on the lower anterior region of the neck, measuring about 5 by 6 cm. Other than that, there are no visible veins, there are no visible scar. However, there's a visible cardiac pulse, there's visible pulsation.
Okay, so on inspection, the doctor says that there is a mild diffuse swelling in front of the neck in its lower part, which measures around
5 by 6 cm.
5 by 6 centimeters. The skin over it is normal. The veins are not prominent or dilated. There are no scars, and color of the skin is normal in this patient. Yes, please.
So next up, I would like to give you, like to ask you to take a sip of water. First of all.
So he wants to see if this swelling moves with deglutition. If the swelling moves upwards on drinking some water or just on swallowing. So first we will observe, we will ask the patient to swallow. Will you please swallow without water? First you swallow. Yes. So we can see that the swelling has moved up, and now we will judge it by asking the patient to take a sip of water. Yes. So he is taking some water, holding it in the mouth, and the doctor will ask him swallow, and he will judge whether the swelling is moving upwards or not.
So could you please swallow now?
So we can see that the swelling moves upwards. There are others, it is the thyroid only which moves on deglutition. So we will say that deglutition test is positive. And why the swelling is moving? The swelling is moving, this thyroid, now we think this is a thyroid gland, and this thyroid swelling moves upwards because the thyroid gland is connected with the trachea by pretracheal fascia. You got my point?
Yes.
Okay.
Next I would like to do the tongue protrusion test.
So the doctor wants to do the tongue protrusion test. He will ask the patient to protrude the tongue. Yes. Can you protrude the tongue, please? You will be seated. You have to do that. Okay. Protrude the tongue. Yes. And move it in, move it out. Yes. Do it. Do it many times. Yes. So we observe that swelling does not move up. If it would have been a thyroglossal cyst, which is a midline swelling, then it would have moved up. So in this case, it has not moved up, which confirms that it could be a thyroid swelling. Okay.
Next, I would like to ask you to do another test. It's called the Pemberton sign.
So doctor wants to perform another test, what is called as Pemberton's sign or Pemberton's test. Now, what is Pemberton's test? You can show us.
I want you to follow me. Just slowly raise your arm.
So please raise your arms above the head. Very slowly. So the arm should be lifted as high as possible. And if there would have been the test positive, then the neck veins would get prominent. The neck veins would get congested. So neck veins are not getting congested. The whole face would have become pink. The whole face would have got congested. There would have been a prominent visible veins over the face and over the neck, meaning that the Pemberton's test is positive. And this is positive because if there is retrosternal extension of thyroid gland. This test can be also positive if there are malignancies, retrosternal malignancies, lymphomas, then because it is due to the compression of superior vena cava that the veins get congested. Okay, done. To repeat basic steps of thyroid examination, we should wash our hands, introduce ourselves to the patient, confirm patient's details, explain examination, gain consent of the patient. We look for any scars, masses, symmetry or asymmetry of the swelling, any pulsations, any prominent veins, any movement of the swelling with deglutition. And here we see the patient has got a swelling which is situated in front of the neck and in its lower part, and this swelling is has got a butterfly shape, and it is swollen. Both the lateral lobes are swollen as well as the isthmus. The lateral lobe size is around 9 centimeters, that is vertical height, and the width of the thyroid gland is about 5 centimeters. We also see neck pulsations, and the trachea appears to be central, and there are no prominent veins. There is also supraclavicular hollowing and infraclavicular hollowing. The patient appears lean and thin, and the skin appears sweaty. The lower border of thyroid gland is also seen, and it is seen just above the suprasternal notch, and the border is well defined. We have to observe any upward movement of thyroid gland on swallowing. You can see the thyroid gland moves upwards. We will also observe when the patient drinks some water, then on drinking some water the thyroid moves upwards. So you can observe here, on drinking a sip of water, the thyroid swelling moves upwards. We will also ask the patient to protrude tongue, and we will check whether thyroid gland moves upwards on protrusion of the tongue.
Like to do the examination of patient of your neck.
So doctor has taken the permission. He wants to do the palpation of the thyroid gland. He is judging the temperature, and he feels that temperature is not raised over the swelling. Then he goes behind the patient and he starts palpating the thyroid gland, and he is palpating one by one. He can't palpate both the sides together. It is to be palpated one side then the other side. And palpation, yes, and he is also tilting the head to the left side as so that the muscles get relaxed and he can palpate it easily. So he is judging for the size of the thyroid gland, the shape of the thyroid gland. He wants to confirm the inspectory findings. So what is the, yes, do it on other side, yes. The palpation on other side, yes. So tell us what you are doing, what you are palpating.
Palpating for the see the size.
So I just show it like this. So you tilt it like this and start seeing the surface of the swelling, whether surface is smooth or it is nodular. So what I feel here, the surface is smooth and the size is around 6 centimeters and 5 centimeters. It is more towards the lateral side than in the midline. And I also look for the borders, and the consistency of the consistency is firm. You have to look for whether consistency is hard, consistency is firm, or consistency is soft. So in this the consistency is firm and it is non-tender. There is no tenderness over the gland. So I can show you. I can tilt it like this, push it a little bit this side, and then palpate it like this. The hand should be kept like this. These are the two, the thumb behind. Keep it like this behind, right? Okay, and then see it. Just below the thyroid cartilage, you have to see. You have to palpate it towards the lateral side, this side as well as this side. Okay. Okay, then what? So he goes above the suprasternal notch and he palpates, he is palpating it, right? Or you can go behind, again I can go behind like this, go behind like this and palpate for the lower border, right? So I can feel the lower border. If I put the fingers like this, ask the patient to swallow, will you please swallow? Yes. So I can see that the lower border is felt. There is no retrosternal extension. What else you would like to do? Okay. So he wants to do another test, what is called as Kocher's test. He will compress the thyroid gland. So he is compressing the thyroid gland. So if there is a stridor, so if you do like this, I have to be in the front like this. Now you can see you compress like this. So you can see that there is some stridor. It means that Kocher's test is positive. Yes, what else you will do?
The lymph node.
So checking for the palpating for the lymph nodes. Again the examiner goes behind the patient. So he is palpating the submental lymph nodes, submandibular lymph nodes, upper deep cervical, lower deep cervical, posterior lymph nodes, occipital, then preauricular and postauricular, then supraclavicular lymph nodes. So there are no lymph nodes are not enlarged in this patient. Yes. What else would you like to do on palpation?
Carotid pulsation.
So he looks for carotid pulsation. Again, it is to be done not simultaneously on both the sides. Please note it. It is to be done one by one. So one side is first palpated, right? Then the other side. Okay. Will you please keep it there, the pause, the fixity again. Yes, now the another he will look for any fixity of the gland. So come forward and look any fixation of the gland. Whether it is fixed or it is mobile. Yes, can show again. So he is checking if there is any, if the gland is fixed or it is mobile. Usually the fixity occurs in case of malignancies, and the consistency in malignancy is hard. Okay. What else he will do on palpation? Okay. So that finishes the palpation of the thyroid gland. So I want to show you some special methods which are to be done for thyroid examination. So there are some special methods. One is called as Pizzolot's method. So what is Pizzolot's method? The Pizzolot's method is that if somebody has got a thyroid swelling which is very mild, right? So at that time you can adopt the method what is called as Pizzolot's method, and the thyroid will become prominent. Now how to do that? That is to be done that you clasp the two hands like this, put the two hands occiput like this, I show you like this, right? And push your head against the resistance of clasped hands. So you push against the resistance of clasped hands. So this is called the Pizzolot's method. The thyroid becomes prominent. Okay, are you pushing? Yes. Okay. So the thyroid becomes prominent. In case when there is a mild enlargement of thyroid. Right? Okay. Then there is another method what is called as Lahey's method. Lahys. Lahey's method. You understand that, right? The Lahey's method is that you have to make the thyroid gland, you have to make it prominent. Now how to make the thyroid gland prominent? The thyroid gland can be made prominent if you push the thyroid gland from one side. Now where to push? You have to push from, you have to see the thyroid cartilage. You cannot push at the trachea. If you push at the trachea, there are chances that trachea is damaged, right? And it may cause choking. It may cause choking. So don't push at what is called as at the tracheal rings. Rather you push at the thyroid cartilage. So one side I am pushing, so I can push it by fingers like this. You understand my point? Or I can push it by fingers like this. Or like this, I put a thumb like this, so I push it like this. So you can see this side has become prominent. So once this side has become prominent, that means this side, the thyroid lobe on this side, it has come out of tracheoesophageal groove. So it comes out of it and it becomes prominent. So once it has come out of tracheoesophageal groove, then you take another hand and start palpating it. Start palpating it. But you have to palpate the posterior medial surface of thyroid gland. So you insert your finger behind the sternocleidomastoid muscle. This is sternocleidomastoid muscle. So push it, insert here like this, and try to feel the posterior medial surface of thyroid gland, right? So this is what we do. Or it can be done, the push can be given by a fist. Push can be given by a fist. There are the two techniques. So I can give a push by the fist like this and start palpating the thyroid gland like this. But you have to avoid the choking. So push should be given at thyroid cartilage and then do it behind the, palpate behind the sternocleidomastoid and try to observe the posterior medial surface of the thyroid gland. So this method is called as Lahey's method. The another method is called Kreil's method. Another method is called as Kreil's method. So Kreil's method is done whenever there is a small nodule is there or small enlargement of thyroid is there. So at that time what you do, you put the thumb. So you put the thumb on the lobe, on the lateral lobe like this. You understand my point? You put the thumb and you just push it a little bit this side. So pushing it this side, pushing it this side, and then put the thumb here on the other side of the lobe and start palpating. And you can just keep it here, ask the patient to swallow. So you swallow. So while swallowing, I can just palpate the thyroid gland. I can observe if there is any nodule. Do you just swallow again? Yes. Swallow again? Yes. So I do now this side. Like this side I push it. So I keep the finger like this. So swallow. Yes. Swallow. So I am palpating like this while swallowing. This is called as Kreil's method. So Pizzolot's method, Kreil's method, and Lahey's method. The another method is called as Coker's method. Coker's or Coker's method. Now Coker's or Coker's method is when there is a large enlargement of thyroid, especially if it is due to thyroid carcinoma. The thyroid carcinoma, it compresses the tracheal rings. You understand my point? Or it damages the tracheal rings due to compression. There occurs decalcification and tracheomalacia in case of long-standing thyroid carcinoma. So with the result, these walls of the thyroid cartilage, they just collapse. They collapse like this. So it becomes like a slit. It becomes like a slit appearance. So it becomes like a sheath of a sword. Like a sheath of sword. You know the sword, when we take the sword, we put it in the sheath like this. So that sheath of the sword is called a scabbard. That is called a scabbard. So exactly it becomes like a scabbard. There is only a slit-like aperture now in the trachea because of compression of the lateral walls due to thyroid enlargement. We call it as scabbard trachea, and it is usually seen on the radiological when we do the radiology of the person. It is a radiological appearance. That slit-like appearance or scabbard trachea is found especially in the carcinoma of thyroid. So now you want to see whether the compression, because now this can cause compression. So once there is a small slit-like appearance, so little bit of more compression will produce stridor. So how to do the Coker's test? you put the two hands like this and try to compress the thyroid gland. So I am just compressing it, right? And if there is a stridor in the patient, then we say Coker's test is positive. You understand me? That is that these are the special tests we do for the thyroid enlargement. Okay, done now. Now what happens that now I tell you how to palpate the trachea when there is a thyroid enlargement. Now you know when thyroid is swollen like this, then you won't be able to see where the trachea is and whether the trachea is deviated or not. So there are two methods for it to check whether trachea is central or it is not central. One is that you take the finger above the suprasternal notch like this, above the suprasternal notch, and you feel for the tracheal rings. You feel for the tracheal rings, suprasternal notch. If you feel for the tracheal rings here, it means that trachea is central. You understand my point? But sometimes what happens is that this area will be occupied like this by the thyroid gland, enlarged thyroid gland. Then you won't be able to insert the finger in the suprasternal notch. So at that time, you just palpate from above. At least you can see the Adam's apple, or you can see this thyroid cartilage. So just go palpate from the thyroid cartilage downwards like this. So where I am feeling the tracheal rings. You understand my point? So you see, first if you judge the thyroid cartilage, I see that thyroid cartilage is in line with the suprasternal notch. It is in line with the nose and suprasternal notch. So it appears that it is in the midline, even if there is a thyroid gland. But Adam's apple we are seeing, so it is at the Adam's apple. You have to see whether alignment of Adam's apple is in line with suprasternal notch and the nose. Or you move down, if some area is bare here, if some area is still free here, then you move down from the thyroid cartilage, start palpating like this, and if you can find the tracheal rings, any of these tracheal rings, and you can judge whether it is in line with suprasternal notch or not. If it is in line with suprasternal notch, right, then it means the trachea is central. So this is how we check for tracheal deviation in case of enlarged thyroid gland. Okay, there's another method called as Nebziger's method. The another method of seeing the exophthalmos or proptosis is Nebziger's method. Sometimes you are not able to see, to make out whether there is a bulging of eyes or not. So we adopt a method what is called as Nebziger's method. So Nebziger's method is that you remain behind the patient, keep the head slightly extended like this, then you look from above. So I look from above like this. You understand my point? I look from above like this over the supraorbital ridges. These are supraorbital ridges. So if there is an exophthalmos, then eyeball will come. It will come in front of supraorbital ridge. It will bulge like this. But here I don't see that eyeball has come out of supraorbital ridges. But if there is an exophthalmos, then along this line, the eyeball will bulge like this along the supraorbital ridge. So if you look like this, you have got doubt or anything, which is called as Nebziger's method, right? Done for assessing the proptosis or exophthalmos. Okay, done.
Student, and today I would like to percuss your chest. Okay.
So the examiner wants to do the percussion on the patient. Yes, please proceed. The percussion is to be done from the below upwards. It is to be done from the resonant area to the dull area. Okay, so the note was resonant, so there is no retrosternal extension. So if I show it again, so we have to go from below, then we have to move up. So from below, from the area of resonance to any dullness. So you can see the note, you can feel the note, it is resonant. So there is no retrosternal extension of the thyroid gland. That finishes the percussion. Yes. Auscultation on the thyroid gland to look for any bruit, to look for any murmur. The murmur outside the heart will be called as bruit, and murmur within the heart will be called as murmur. It is just like a blowing sound, like shh, 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 shh. And if that is present, that is due to the increased vascularity. That is due to the increased vascularity in the thyroid gland that you will find a bruit. So please proceed.
So, the morning and afternoon, I'm going to auscultate your next session.
So by the bell of the stethoscope, she is auscultating on one side, then she will auscultate on the other side, and she is judging for any bruit on the thyroid gland. So there is no bruit heard. We only forgot in palpation. In palpation, we were supposed to also check for any thrill. So on palpation, please check also for thrill. Okay, that finished the auscultation. Yes. Yes.
Dear medical student, I would like to examine your eyes. Can I proceed?
So we do examination of eyes now. The doctor comes in front of the patient, right? And she adopts a proper position of the patient as well as herself. Her eyes are in line with the eyes of the patient, and she is now trying to do the examination of the eyes. Yes, please, carry on.
On inspection, there is no ptosis, there is no widening of palpebral fissure, and there is no exophthalmos.
So the doctor says there is no bulging of eyes, there is no proptosis, there is no exophthalmos, and there is no widening of palpebral fissure or any lid retraction. And there are no jerky movements of eyes or nystagmus. That was inspection she just observed. Yes. How will you look for exophthalmos? If the patient has got exophthalmos and you want to look for proptosis or exophthalmos, you can go by the side of the patient like this and look it like this. If the eyes is bulged or not, the positioning should be like this. Or you can go behind like this, slightly tilt the head slightly and look from above if there is any proptosis or exophthalmos. Right? And if you see in this patient you will see that normally the upper eyelid is covering the limbus at 11, 12 and 1 o'clock position. And lower eyelid covers at 6 o'clock position. It covers the limbus. But in this patient, if you see here, it doesn't cover the iris or it doesn't cover the limbus. You can see there the sclera is exposed above as well as below here. You can show it, the sclera is exposed. Means that there is a lid retraction. There is a lid retraction in this patient. And there is a staring look in this patient. And it appears that there is an infrequent blinking. So three things you have to see. You have to look for blinking of the eyes, you have to look for any staring look, and you have to look for lid retraction. So in this patient there is a lid retraction, there is an exophthalmos, and there is what is called as, there is a staring look. So it means that Stalwart sign is positive in this patient. Infrequent blinking, lid retraction, and lid lag. You understand my point? The staring look will be called as, or widening of palpebral fissure, this sign will be called as Stalwart sign. Stalwart sign positive in this patient. What else you would like to check as far as eyes are concerned? So you will check for any lid lag. So how to do lid lag?
I will do the lid lag test. for
Yes.
you. Okay. You need to see the tip of the pen and follow the movement without moving your head.
So she is looking for whether the upper lid is pursuing along with the pen. It follows the movements of the pen, or go up and down again. You show up and down. So it goes up, it goes down. So here it is normal, but in that patient, what you are seeing there, the upper lid doesn't cover the eyes. So there is a lid lag. So lid lag in that patient is positive. In this patient, there is no lid lag sign. What else you would like to see? You would like to see the movements of the eyes. So check for movements of the eyes.
I will check your movement of the eyes.
Yes.
Follow the tip of the pen without moving.
So following the tip of the pen. Okay. Yes. Up, down. Yes. The right side and left side. Without the head should not move. Or if you want, you can stabilize the head like this. But if patient is educated, well educated, then he won't move the head. Yes, please do it again. Yes. Okay. Okay. So in the patient, the eyes, the patient can move the eyes. So there is no weakness of the muscles. There is no paralysis. Because in hyperthyroidism, due to the deposition of mucopolysaccharides and due to the antigen antibody reaction, the muscles may get destroyed. It may cause squint. And you also have to look other eye signs, like you have to look for any congestion or redness of the eyes, any ulcerations. And you also look for any lateral loss of eyebrows. So in this patient, we don't see there is any lateral loss of eyebrows. The eyebrows are equally distributed on both the sides. So that finishes the so far the sum of the examination of the eye. What else you would like to see in the eyes? You can just wait. You can just close. Yes. Introduce.
Good afternoon. I'm Bashir medical student. I want to do eye examination.
Okay.
Please.
So she wants to look if the patient shows the wrinkles on the forehead during the movements of the fingers. Okay.
Okay, please look at my finger and follow my finger.
So she asks the patient to fix the eyes on the finger, then she moves finger up and down, move down. Yes, move again up. So we can see he can wrinkle the forehead. The patient can wrinkle the forehead. If there is absence of wrinkles, you can show the, yes, go up and see. Yes, he can wrinkle the forehead. That means Geoffroy's sign is not positive. If there would be loss of wrinkles, then we say that Geoffroy's sign is positive. Yes, okay, done. Now she has talked about the eye signs in hyperthyroidism, and she tried to elicit all the signs of eye in case of hyperthyroidism. But I want to show you some of the images and video clips, and I would also like to explain about the abnormalities that occur in the eye in case of hyperthyroidism. Now let me show it to you. This is an eye. Normally the upper eyelid and lower eyelid covers the limbus. This is the limbus, the corneal margin. This in normal people, the upper eyelid covers the limbus at 11, 12 and 1 o'clock position. and lower eyelid covers the periphery of this corneal margin or limbus at 6 o'clock position. So normally in these positions the sclera is not exposed. You can see here the sclera, the whitish area, but at these areas the sclera is covered and not visible normally. The initial changes that take place in thyrotoxicosis in the eyes are lid retraction, lid lag, and infrequent blinking. And among these, the earliest to appear is lid retraction. And this lid retraction results in widening of palpebral fissure. Now you can see here the earliest sign that arises in eyes of thyrotoxicosis patients is the lid retraction. Lid retraction of the upper eyelids, which is the first thing that appears in the eyes of hyperthyroid patients. And because of this lid retraction, the sclera gets exposed. So you can see here the whitish area, the sclera gets exposed, and there is widening of palpebral fissure. So you can see here, from here to here, the palpebral fissure gets widened. This earliest sign, the lid retraction, is called dull Rempli's sign. So it will be called as dull Rempli's sign when there is lid retraction in hyperthyroidism. This lid retraction is due to tonic contraction of levator palpebral superioris, thereby exposing sclera above the superior limbus, which usually remains covered by upper eyelid at 11, 12 and 1 o'clock position. The next change that occurs in the eyes of hyperthyroidism is bulging of eyeballs, which is called as proptosis or exophthalmos. So the next change in the eyes will be exophthalmos, which is bulging of eyeballs. So there will be more and more widening of palpebral fissure. Now you can see here there is lid retraction above as well as below. So now because of exophthalmos, the lower eyelid is also retracted and the sclera here also gets uncovered or exposed. Therefore, there is a widening of palpebral fissure, and this gives a frightening look, or this gives a staring look, and this frightening or staring look is called as Sittelwog's sign. And this Stelwag sign, as I said, is associated with lid retraction and widening of palpebral fissure, and also associated with infrequent blinking. Even if there is blinking, that blinking becomes incomplete or partial. Now I must tell it here that the lower eyelid retraction has nothing to do with upper eyelid retraction. The upper eyelid retraction is due to the tonic contraction of levator palpebral superioris, while as the lower lid retraction is due to exophthalmos, and it is not due to tonic contraction of the lower eyelid, but because of exophthalmos. You can see here there is a bulging of eyeballs, and as I said, this bulging is called as exophthalmos, which usually occurs after the lid retraction of the upper eyelids. And you can also appreciate here the wide palpebral fissure because of upper as well as lower eyelid retraction. And you can see the sclera, that is this whiteness, is uncovered and exposed both at the upper end as well as at the lower end. The look here is very frightening and staring. As I said, the staring and frightening look with infrequent blinking is called as Stelwag's sign. So because of the tonic contraction of upper eyelid and because of the upper eyelid retraction, there occurs lid lag when the patient looks downwards. When the patient looks downwards, the upper eyelid doesn't fall covering the eyeball, it lags behind, and this lid lag is called as von Graeff's sign. Now, how to test the lid lag, or how to find that there is a lid lag in the patient? You have to fix the head of the patient to prevent neck flexion or extension, and then hold your right index finger in front of the eyes at a distance of 40 centimeters and ask the patient to follow the finger when the finger is moved upwards and downwards. When the patient tries to follow or look downwards, the upper eyelid lags behind. The upper eyelid shows a very slow movement in covering the eyeball, or it may not be totally present, it is so much retracted that it doesn't come down, or it is unable or slow or difficult to follow downward movement with the movement of the finger. Therefore, large portion of sclera remains exposed or uncovered by the upper eyelid. This lid lag is called as, when this lid lag is present, we say von Graeff's sign is positive. You can see here the person tries to look downwards. Normally when a person is looking downwards, the upper eyelid should also come down and cover the sclera. But because of the lid retraction or tonic contraction, the lid lags behind when patient looks down. So there is a lid lag. You can see here also the patient looking down, but the upper eyelids don't cover the eyeballs because of tonic contraction of the upper eyelids. So it lags behind when the patient tries to look downwards. When the disease progresses, there is more and more bulging of the eyeballs due to retroorbital edema and fat deposition, or due to inflammation, or due to antigen antibody reactions going in the retroorbital tissue, giving rise to edema and causing bulging of the eyes. Normally eyes don't project beyond the supraorbital ridges. These are supraorbital ridges, but when there is a gross proptosis or exophthalmos, then these eyeballs, they project beyond the supraorbital ridges, or they come in front of supraorbital ridges, and this can be better judged by Nebziger's method as shown earlier. The Nebziger's method will tell you about the degree of exophthalmos, or about the degree of the bulging of eyes. So you can see in this patient the staring look, frightening look, and with the infrequent blinking, and this staring look, wide palpebral fissure, infrequent blinking is called as Stelvog's sign, as already said. And you can also notice here bulging of eyeballs, proptosis or exophthalmos. So if you look by the side of the patient, you can easily detect the bulging of eyeballs that have bulged beyond the supraorbital ridges. You can also notice here exophthalmos or proptosis. You can see this is the supraorbital ridge, so it has bulged beyond this supraorbital ridge. And if you look from above, then you can notice the degree of exophthalmos or degree of proptosis. Normally the upper eyelids can be everted like this. So you can see here the normally upper eyelids being everted. But what happens when there is bulging of eyes? What happens when there is proptosis or exophthalmos and lid retraction? So at that time, it is either impossible to evert the upper eyelid in case of thyrotoxicosis. But if there is exophthalmos due to intraorbital mass, then the eversion of upper eyelid is possible. So the lack of eversion of the upper eyelid or difficulty in everting the upper eyelid occurs in case of thyrotoxicosis, which is called as Gifford sign. So Gifford sign is positive if upper eyelid is not being everted because of the exophthalmos due to thyrotoxicosis. But as I said that eversion of the upper eyelid is possible if there is intraorbital mass or if exophthalmos is due to intraorbital mass. So one can differentiate whether the exophthalmos is due to intraorbital mass or due to thyrotoxicosis by testing the lid eversion, the upper eyelid eversion. Now there is another sign that occurs in eyes in thyrotoxicosis, and that is called Mobius sign. The Mobius sign is lack of convergence of eyes when a finger is kept or a pen or any object is kept away and in front of eyes at a distance of at least 1 meter, and then when you bring the finger closer towards the point between the two eyebrows, so you can see here patient is asked to fix his eyes at the tip of the finger, and when the finger is kept at least 1 meter away and when it is brought closer and the patient's eyes are being kept fixed at the tip of the finger, when the finger is brought closer to the point between the two eyebrows, the eyes don't converge. Normally it should converge. So there is lack of convergence, which is called as Mobius sign. Normally when the patient looks upwards, there will be transverse wrinkles on the forehead, but in case of thyrotoxicosis there will be loss of wrinkles on the forehead when the patient tries to look upwards. This is called positive Geoffroy's sign, and this can be detected by asking the patient to look or pursue the movement of finger upwards. The other signs that can appear in the eyes because of the thyrotoxicosis are the conjunctivitis, the corneal ulceration, and defect in the acuity of the vision, or there can be secant or there can be ophthalmoplegia. So this was about the abnormal eye signs in case of thyrotoxicosis. Now let us go back to clinical class and see what discussion is going on there.
Good afternoon, sir. So I would like to do some examination on you. Is it okay for you?
So the doctor wants to do the relevant general examination. Now I want to tell you here that the relevant general examination can be done before or it can be done last of all. The choice lies with you. Whether you want to do first general examination or you want to do last of all relevant general examination. So please proceed and do the relevant general examination in the patient.
Can you give me your hand? Okay.
So she is looking for any palmar erythema. You have to show them. You have to move this side. Yes, yes, like this. Yes, exactly. So looking for any palmar erythema. So she is also looking for any clubbing of the fingers, because there will be acropathy in case of hyperthyroidism. And
The hand is feel warm and hot
so hand feels warm and hot,
and sweaty.
and it feels sweaty. There will be usually in hyperthyroidism excessive sweating, as well as there will be generalized, the patient will have generalized wasting of the muscles. The patient will look lean and thin in case of hyperthyroidism, while as in hypothyroidism he will have obese look. The face will be swollen. The skin will be thick. While as in case of hyperthyroidism, the patient is usually overactive and has got lean and thin build because of excessive catabolism. Yes.
Now check for fine tremors.
So she is checking for fine tremors. So that can be done by eyes open and eyes closed. Eyes open and eyes closed. So you can put the paper and see if there is any tremor. So you can see the fine tremors is present. Okay. Then
I will check for the pulse.
so she checks for the pulse.
Pulse is 105.
So pulse is to be felt for at least 1 minute. The ideal is 1 minute, or you can feel it for 30 seconds, but ideal is 1 minute. So she says that the patient has got tachycardia, it is more than 100, which is a feature of hyperthyroidism.
I would like to check for the blood pressure also.
So she wants to check the blood pressure, because in hyperthyroidism the blood pressure is usually high. Then what else? What else for the peripheral signs? So she has to look for any peritibial edema. So look for peritibial edema. So she looks for any peritibial edema. We see the skin is normal. We don't see any peritibial edema. Whereas in case of hyperthyroidism, there can be, the legs can be swollen, non-pitting edema. Sometimes like elephantiasis. So much the legs will be swollen. So we don't see any peritibial edema in this patient. Okay. Then what else you will look for as far as this is concerned, what is called as far as peripheral signs are concerned, we look for reflexes. In hyperthyroidism there will be hyperreflexia. In hypothyroidism there will be hyporeflexia or delayed reflexes. So when we check for deep tendon reflexes, we find that there is hyperreflexia. So anybody has got the hammer? Give the hammer? Yes. Okay. So you can check for any you can elicit the reflexes. You can check the biceps reflex. You can check that arm first. You can check. Yes. So it is to be done like this. Let me show. It is to be done like this. So slightly flex it, slightly keep it slightly like this, and then do it. So I can see. You can see the reflex. The reflexes in this patient is normal. You have to see all the reflexes. You have to check for the triceps, like keep it like this, and check for the triceps also. The reflexes in this patient is normal, and check for the ankle reflexes, especially the ankle, the slowed and delayed reflex, especially of ankle reflex. In case of hypothyroid. So we see here the reflexes are not slow or delayed, they are normal reflexes. In hyperthyroidism, it will be hyperreflexia. That was the another sign we elicit as far as general examination is concerned. Is there any other you will do as far as general examination is concerned? Okay. So check for any proximal muscle weakness. Proximal muscle weakness. Now proximal muscle weakness should be done. If you are doing lower limbs proximal muscle weakness, then patient should be able to get up from the sitting position unsupported. He should be able to stand up himself without any support. Now how to do that? That you put both the hands on the head like this, and then you try to get up, or you put hands like this and then try to get up. Now we got a here. He will show you how it is to be done. So please put the hands here like this and try to get up. So he can get up. He doesn't take any support, or he is not unable to get up. So he doesn't have proximal muscle weakness of the hips. You understand my point?
Yes.
And the upper, you just raise it like this and raise down. So raise up again. So we don't see that there is any proximal muscle weakness or proximal muscle myopathy in the patient. Meaning that in case of hyperthyroidism, the hyperthyroidism patients, they have myopathies also. Okay, done. We are now concluding here. Now I must say thanks to all of you. Thanks to the Mr. Lee, right, who himself presented as patient, right, and it will be a good contribution. When the others will see this video, it will serve for the educational purposes, right? And I thank all the guys who came as examiners and who examined the patient, and I thank you also who showed us the video background. Then our usual the camera operators, I also thank them. Right? I thank you all. You have been always supportive, right? And you have been very enthusiastic, and you got a very keen interest in learning. I hope in the future, by the grace of God, you will prove very good doctors, and you will try to minimize your mistakes. That will be my hope. So I thank you. So give a big hand to the volunteers. Here, the one thing, you see, we now know how to do the examination of the thyroid gland, right? How to examine the goiter. But we are not able to know why the patient develops hyperthyroidism. So that is the another part which deals with the causes of hyperthyroidism. So unless you know the causes of hyperthyroidism, you won't be able to diagnose why patient develops this swelling. If I ask you, okay, this patient has got a swelling, I ask you why he developed swelling, will you be able to tell me? You won't be able to tell you, because for that you need knowledge. You need to know the causes of hyperthyroidism. You got my point?
Yes.
Then only you will be perfect as far as this topic is concerned. So with these words, I thank you all and all the best in future.